Welcome to the deep dive. Today, we're getting into something really fundamental for health. It's the world of preventative and social medicine.
Yeah, and we're using Park's textbook, the 27th edition, as our guide. It's pretty much a cornerstone text in the field.
It really is. And it's about looking beyond just, one person getting sick.
Right. It's about populations, health, disease, how it all works on a bigger scale, from ancient history right up to today's outbreaks.
So our mission here, we want to pull out the key stuff for you. The core ideas, the history, how thinking about health has changed.
Basically give you a solid framework so you feel genuinely clued in on this whole vital area.
Exactly. Let's get into it. Okay, so to really get where preventive medicine is now, we kind of have to look back, don't we? How did we even get here? How's the understanding of health and disease changed over, well, centuries?
Oh, it's been quite a ride. The source, Parks, it takes you way back. Primitive times, people thought disease was, magic, spirits.
Right, like curses or something.
Yeah, exactly. Or maybe the gods were angry. So you had charms, rituals, sacrifices even, all based on these external supernatural ideas.
Wow. So different from today's scientific view. How do we make that huge jump?
Well, it wasn't really a jump, more like a long, slow climb, built up over ages, different cultures adding pieces. Like the ancient Egyptians, they had doctors, pretty organized health practices.
Okay.
Mesopotamians had actual health laws in their codes. Then the Greeks, Hippocrates is the big name, obviously. He pushed for more rational observation, thinking about the body itself.
Ah, the four humors theory, right.
Yeah.
Black bile, yellow bile.
That's the one. Dominated thinking for ages. And the Romans, they were brilliant engineers, and that applied to health too. Sanitation, aqueducts, public baths, proper sewers.
They really got the public health infrastructure idea, the environmental side.
Absolutely. A massive insight there. Changing the environment could change health outcomes for everyone, even if they didn't know about germs yet.
Okay, so that's antiquity. What about the Middle Ages? Did things stall?
Not entirely. Knowledge was kept alive in monasteries, that's true. And Arab medicine made huge contributions, especially in clinical practice and pharmacology. Then the Renaissance kind of reignited that scientific curiosity, digging back into anatomy, how the body actually works.
And that sets the stage for what we often think of as the real start of modern public health, right? The 18th and 19th centuries.
Exactly. That's when things really took off. Industrial revolution, cities booming, but also terrible conditions, overcrowding, filth.
Yeah, you read descriptions, it sounds awful.
And the disease outbreaks were devastating, so people started connecting the dots. The environment, the sanitation, the sickness. Pioneers in that era realized improving living conditions, just basic hygiene and sanitation, could dramatically cut down disease.
Even before germ theory was fully established.
Right. That was the key thing. It showed that public action worked. A huge societal aha
moment. And it wasn't just the science changing. The whole idea of what health has changed, too. It's not just about not having a disease.
Yeah, the source really drills down on this. The WHO definition is probably the most famous.
Yeah.
A state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
Complete well-being. That's a high bar.
It is. And it tells you health is multidimensional. Physical, sure, but also mental, social. Some even add environmental, spiritual, and well-being itself is tricky. There's how you feel subjective.
Right.
And then there are things we can measure, objective signs. The big takeaway is that health is complex, it's holistic, it's way more than just what a doctor treats in a clinic.
So for you listening, thinking about your own health or your community's health, it means considering a much wider picture.
Precisely. And that wider view directly shapes what preventive and social medicine does today. It's not just preventing disease, it's promoting good health in the first place, treating illness when it happens and rehabilitation afterward.
Helping people recover function.
Exactly, and it's deeply linked to socioeconomic factors. You really can't separate a population's health from the conditions they live and work in. Poverty, education, access, it all plays a role.
Okay, so that's the historical sweep. Now let's dig into some key concepts, the frameworks this field uses. One really powerful one is the iceberg phenomenon of disease. What's that about?
Ah, yes. This is fundamental because it totally flips your usual idea of sickness. What we normally see, the people diagnosed, going to the doctor, the hospital cases.
The obvious stuff.
That's just the tip of the iceberg, the visible part. But the vast majority of the disease burden is hidden underwater, submerged.
Down there.
All sorts. Undiagnosed cases, people who have the disease but don't know it yet. Subclinical infection, someone's infected, maybe even spreading it but has no symptoms. Think asymptomatic spread.
We've certainly heard a lot about that recently.
Exactly. And then there are early stages of chronic diseases like pre-diabetes or early hypertension. And maybe biggest of all, the huge number of people who just have risk factors. They're not sick yet, but they're vulnerable.
So if you only count the diagnosed cases, you're missing most of it.
Totally. You're getting a skewed picture. And the key insight here for public health is huge. Just treating the tip, the clinical cases, will never solve the underlying problem.
You have to go below the surface.
You absolutely have to. Focus on finding those hidden cases, managing the risk factors in the community, stopping illness before it even starts or gets serious. It shifts the focus from reaction to proaction, from treatment to prevention and early detection.
Okay, that makes a lot of sense. Now, what about why people get sick? We used to think like one germ causes one disease, right? Simple.
Yeah, the old single cause idea. But for most major health problems today, especially chronic ones, it's way more complex. The source talks about the web of causation.
A web, like a spider web.
Kind of. Imagine a tangled network. Take something like a heart attack, myocardial infarction. There's rarely just one cause. Parks uses it as a great example. You've got threads like genetics, maybe smoking, poor diet, high stress.
Socioeconomic status. Access to care.
All in the web. Plus, biological factors, high blood pressure, cholesterol levels, they all interact, influence each other. It's not a simple chain reaction. It's a complex system.
So the insight isn't just, it's complicated.
The insight is that because it's a web, just snipping one thread might not be enough. If someone quits smoking, that's great. But if their diet, stress, and genetics are still major issues,
The risk is still high.
right. Effective prevention often means understanding the specific web for a particular disease in a particular community, and then intervening at multiple key points. It pushes you away from looking for single magic bullets.
Got it. Complicated causes need multi-pronged solutions. This feels connected to another core idea, the natural history of disease. What does that mean?
Okay, so this isn't your personal medical history file. It's about the typical progression of a disease if you don't intervene, like a timeline of how it usually unfolds in a person or population.
Without treatment.
Exactly. It starts from a state of health. Then comes the pre-pathogenesis phase.
Yeah.
This is before the actual disease process starts in the body, but the factors are interacting. The agent, the host, the environment, those threads in the web are active.
So you're exposed or maybe susceptible, but nothing's actually wrong inside you yet.
Correct. Then pathogenesis begins. The disease process is actually underway biologically, maybe silently for a long time, cells changing, infection multiplying, whatever it is.
Still below the surface of the iceberg.
Precisely, until you hit the clinical horizon. That's the point where signs or symptoms appear. The disease becomes detectable by a doctor or the person feels sick.
Uh-huh. The tip emerges.
That's it. And from there, the timeline leads to outcomes. Maybe you recover fully, maybe you develop a chronic condition or disability, or maybe, unfortunately, death.
And why is understanding this timeline so important?
Because it tells you when different types of interventions are possible and most effective. You can intervene in pre-pathogenesis to stop it ever starting, or during pathogenesis to catch it early. It maps prevention strategies onto the disease course.
Okay, so these concepts, the iceberg, the web, the natural history, they're like the building blocks for the actual science of epidemiology.
Absolutely. Epidemiology is basically the engine room of public health. It's defined as the study of the distribution, like where disease occurs, who it affects, when, and the determinants, the why, the causes, the risk factors of health issues in populations.
And not just studying it, but using that knowledge.
Right. The definition includes applying the study to control health problems. So its main aims are, 1, describe the health status of populations, 2, identify the causes of disease, and 3, provide the data you need to plan, implement, and evaluate health services and interventions. It's the evidence base.
So how do these epidemiologists, these health detectives, actually measure disease? You mentioned incidence and prevalence earlier.
Yeah, those are the two big ones for measuring frequency. They tell you different things. Incidence looks at new cases appearing in a population over a set period of time.
Like how many people caught the flu this month?
Exactly. It's a measure of the rate at which people are developing the disease. It reflects the risk of getting it. High incidence means something's actively spreading or conditions are ripe for it.
Okay, so that's new cases. What's prevalence?
Prevalence counts all cases, new and old, that exist in a population at a specific point in time, or sometimes over a period. It tells you how widespread the disease is overall.
Like how many people have diabetes right now?
Perfect example. So incidence is like your smoke detector. It alerts you to new fires, new risks, tells you where immediate action might be needed. Prevalence is more like assessing the total fire damage. It tells you the overall burden, how many resources you need for ongoing care and management.
Gotcha. New versus existing. And the source also mentions mortality rates.
Oh, yes. Death rates, crude rates for the whole population, specific rates for certain causes or age groups, standardized rates to allow fair comparisons between populations. They're all crucial outcome measures.
Okay, so that's measuring what's happening. How do they figure out the why? You mentioned study designs.
Right. So the simplest are descriptive studies. They just describe patterns. Who gets sick? Where do they live? When does it happen? Looking at disease rates by age, sex, location, time trends.
Like mapping cases, you mentioned John Snow and cholera.
Classic example. He mapped where cholera deaths were occurring in London and saw they clustered around a specific water pump. Purely descriptive, but pointed strongly to the source. A map can be incredibly powerful.
So description gives you clues. What's next?
Then you move to analytical studies to test those clues, to look for associations between exposures and diseases. Two main types. Case control studies. You start with people who have the disease, the cases, and you find similar people who don't have it, the controls. Then you look backward in time, comparing their past exposures. Were the cases more likely to have been exposed to factor X than the controls?
So you look back from sickness to exposure.
Exactly. You often calculate an odds ratio to see how much higher the odds of exposure were among cases. It's efficient for rare diseases.
Right. What's the other type?
Cohort studies. These work the other way around. You start with people who are healthy, but you identify groups based on whether they're exposed to a factor or not, say, smokers and non-smokers.
Okay, defined by exposure first.
Yes. And then you follow both groups forward over time to see who develops the disease. You're comparing the incidence of disease in the exposed group versus the unexposed group.
So you look forward from exposure to sickness.
Precisely. This gives you a relative risk how many times more likely the exposed group is to get the disease. Great for common exposures and understanding the timeline.
And then there are experiments.
Right. The gold standard for testing interventions, like a new drug or vaccine, is the experimental study. The classic is the randomized controlled trial, or RCT. You randomly assign people to get the intervention or a placebo standard care and compare outcomes. Randomization helps ensure the groups are comparable.
Okay, so with all that understanding, the iceberg, the web, the timeline, the epi tools, we get to the practical part. What do we actually do about it? The strategies for prevention and control. Parks outlines these levels of prevention.
Yes, and they map really neatly onto the natural history of disease we talked about. The very first level, the most upstream, is primordial prevention.
Primordial, like really basic.
Yeah, it's about preventing the risk factors themselves from even developing in the population in the first place. Think big picture, policies, environmental changes.
Like taxes on sugary drinks to reduce consumption before obesity becomes widespread. Or urban planning that encourages walking.
Perfect examples. It's about shaping the environment and social norms so unhealthy exposures or behaviors don't become common. It acts way before pre-pathogenesis even begins.
Okay, what's next?
Primary prevention. This happens during pre-pathogenesis. You're taking action to prevent the disease process from starting. Immunization is the classic example.
Stop the disease before it gets a foothold. Health education, too.
Absolutely. Promoting healthy behaviors, using protective equipment like seatbelts or condoms. It's direct prevention of disease onset.
Got it. Then comes secondary prevention.
Right. This kicks in during the early pathogenesis phase, often before symptoms are obvious below the clinical horizon on the iceberg. The goal is early detection and prompt treatment to slow or stop the disease progression.
Ah, so screening fits here.
Exactly. Screening tests like mammograms, pap smears, blood pressure checks. Find it early when treatment is likely more effective.
Catch it while it's small.
Yeah.
Makes sense. And the last level.
Tertiary prevention. This is for when the disease has already happened, maybe caused some damage. It happens after the clinical horizon. The aim here is to limit disability, prevent complications, and help people rehabilitate.
Like physical therapy after a stroke. Or managing diabetes to prevent complications.
Precisely. It's about improving quality of life and managing the long-term consequences of the disease. So, you see the flow. Stop the risk factors, stop the disease, stop the progression, limit the damage.
That's a really clear framework. And you mentioned broader goals too, like control, elimination.
Yeah, beyond individual prevention, we think at population level. Disease control means reducing the number of cases, the transmission, to an acceptable level. It's ongoing effort. Elimination is more ambitious, stopping transmission completely in a defined geographic area, like a country. Measles elimination is a goal in many places.
But the disease might still exist elsewhere.
Right, which leads to the ultimate goal for some diseases, eradication. That means wiping it out completely, globally, forever. Smallpox is the prime example of successful eradication. Polio is getting close.
You've mentioned immunization a few times as key primary prevention. Let's zoom in on that. How does it actually work, basically?
Sure, it's all about leveraging our own immune system. The core idea is generating immunity without causing the disease. We talk about two main types: active immunity. That's when your own body is stimulated to produce antibodies and, crucially, memory cells. This can happen naturally after an infection or artificially through vaccination. The key is your body learns to fight it, giving long-lasting protection.
Right. It remembers the enemy. What's passive immunity?
Passive is when you're given ready-made antibodies from somewhere else, like a baby getting them from mom via placenta or breast milk, or getting an injection of anti-serum, like for rabies exposure.
Ah, so you didn't make them yourself.
Exactly. It provides immediate but temporary protection because your body didn't learn to make them and they eventually degrade. No long-term memory.
So vaccines are all about triggering that active immunity safely.
Precisely. And there are different ways to do it. The source mentions several vaccine types. Live attenuated vaccines use a weakened version of the actual virus or bacteria. It replicates a bit, enough to trigger a strong immune response, but doesn't cause significant illness.
Like the MMR vaccine.
Yep. Then there are killed or inactivated vaccines using bugs that have been killed by heat or chemicals. They can't replicate, so they often require multiple doses or boosters.
Okay.
Toxoids are vaccines against bacterial toxins, like for tetanus or diphtheria. They use an inactivated version of the toxin. And then newer technologies like subunit vaccines use just a piece of the pathogen, like a protein, or recombinant vaccines use genetic engineering to produce an antigen. Lots of different strategies.
That's amazing science.
Yeah.
You know, one thing Parks really stresses is the cold chain. Why is keeping vaccines cold so critical?
Oh, it's non-negotiable. Vaccines are biological substances, often very fragile. Heat, sometimes even freezing or light, can damage them and make them lose potency, basically, stop them from working.
So all that effort is wasted if they get warm.
Exactly. The cold chain is the whole system. The fridges, the freezer packs, the transport boxes, the temperature monitoring. The procedures designed to keep vaccines within their specific required temperature range, usually between +2 and +8 degrees Celsius, right from the factory to the moment they're administered.
It's a logistical feat.
It really is, especially in remote or low-resource settings. That's why equipment like ice-lined refrigerators, ILRs, are so important. They can maintain temperature for many hours, even if the power goes out.
And you mentioned those little stickers, VVMs?
Vaccine vial monitors, yeah, they're fantastic. A small square on the vial that changes color gradually and irreversibly if exposed to too much heat over time. It gives the health worker a simple visual cue. If the inner square is lighter than the outer circle, use it. If it's the same color or darker, discard it.
Wow, that's clever. Built-in safety check.
It avoids using damaged vaccines and builds confidence. The source also mentions adverse events following immunization, AEFIs. It's important to monitor for any reactions, investigate serious ones properly, and classify them to understand if they're actually caused by the vaccine or just coincidence. Maintaining safety surveillance is key for trust.
And big programs like the Universal Immunization Program, UIP, show this in action on a massive scale.
Absolutely. One of the most successful public health interventions globally, saving millions of lives, all built on these principles of immunity, vaccine tech, and logistics like the cold chain.
Okay, another big strategy you mentioned for secondary prevention is screening, finding disease early. How is that different from just getting a test when you're sick?
Yeah, it's a common point of confusion. A diagnostic test is for someone who already has symptoms or a reason to suspect they have a specific disease. The goal is to confirm or rule out that diagnosis.
Right, you feel bad, you go to the doctor, they run tests.
Exactly. Screening is different. It's done on people who seem perfectly healthy, people without symptoms. The aim is to sort through a population and identify those who might have the disease or be at high risk but don't know it yet.
So you're actively looking for hidden disease in the healthy population.
Precisely. You're trying to catch diseases early, often in that pre-symptomatic phase of pathogenesis, when intervention might be more effective, less invasive, or lead to better outcomes.
But you can't just screen for everything under the sun, right? There must be criteria.
Definitely not. The source lays out clear principles. First, the disease itself. It should be an important health problem, serious enough to warrant the effort. It needs to have a detectable early stage, a decent period between when you can detect it and when symptoms appear. And crucially, there must be an effective and acceptable treatment available.
So no point finding it early if you can't do anything about it.
Exactly. That just causes anxiety for no benefit. And the test itself has criteria too. It needs to be acceptable to people, easy, not too uncomfortable or expensive. It should be reliable, meaning repeatable. And most importantly, it has to be valid.
Valid, meaning accurate.
Yes, accurate in two specific ways: sensitivity and specificity. Sensitivity is a test's ability to correctly identify people who do have the disease. A high sensitivity means few false negative. It doesn't miss many people who are actually sick.
Okay, catches the sick people. What's specificity?
Specificity is the test's ability to correctly identify people who do not have the disease. High specificity means few false positives. It doesn't wrongly label healthy people as potentially sick.
Right, doesn't worry the healthy people unnecessarily.
Exactly. And there's often a trade-off. Making a test super sensitive might make it less specific and vice versa. So the key insight for you is understanding this balance. Choosing a screening test, setting the cutoff points, interpreting the results, it all involves weighing the potential benefits of catching disease early against the harms of false positives. Anxiety, cost of follow-up tests, and false negatives, missed opportunity for early treatment.
And how is screening actually done? Is it always for everyone?
Not necessarily. There's mass screening, where you offer the test to a whole eligible population group, like newborn screening. Or there's selective or high-risk screening, where you only target individuals who have known risk factors for the disease, making it more efficient.
Okay, to bring all this together, let's touch on a couple of specific diseases Parks mentions, just to see these principles in action. Measles is a good example.
Measles is perfect. The source highlights its extreme contagiousness, that's epidemiology, describing distribution and determinants, airborne transmission. You see the natural history, it causes significant illness, complications.
And the prevention.
Primary prevention through vaccination. The measles vaccine is highly effective, triggering active immunity. The push for elimination demonstrates that population-level strategy, relying on achieving high vaccination coverage to get herd immunity and stop transmission. It shows the power of a specific protection measure.
Okay. And then the one we can't ignore, COVID-19.
Right. COVID-19 was like a real-world high-speed course in all of this. We saw epidemiology in action, tracking the pandemic spread, identifying variants, figuring out transmission droplets, aerosols. Determinants included everything from age to underlying conditions to social factors.
And the iceberg phenomenon was huge, wasn't it? All the asymptomatic spread.
Absolutely massive. It drove transmission and made control incredibly difficult. And the response used all the levels. Primary prevention, vaccines developed and deployed rapidly, facing huge cold chain logistics, but also non-pharmaceutical things like masks, distancing, trying to block transmission.
Secondary prevention.
Testing to identify cases early, contact tracing to find others who might be infected, trying to break chains of transmission, and tertiary prevention in managing severe cases, dealing with long COVID.
It really showed that web of causation, too, how individual behavior, government policies, global travel, biology all tangled together.
Completely. It was a stark, modern example of nearly every concept we've discussed, playing out on a global stage, reinforcing why understanding preventative and social medicine is so crucial.
Wow. Okay. That was quite a journey. We went from ancient ideas about spirits causing illness,
all the way through the Romans, the rise of public health in the 19th century,
to dissecting these core concepts today. The disease iceberg, that web of causation, the natural history timeline.
We looked at the tools epidemiology gives us: incidence, prevalence, study designs.
And the strategies, those levels of prevention, primordial right through to tertiary, plus the specifics of immunization, the cold chain.
And screening, understanding sensitivity and specificity.
It really paints a picture of health as something much bigger than just individual biology.
Definitely. It's about populations, environments, systems. This deep dive, drawing on Parks, hopefully gives you that framework, that lens to see health challenges differently, whether it's in your own life, your community, or globally.
So here's something to maybe mull over as we wrap up. Knowing all this, the complexity, the web of factors, the different points where we can intervene from policy down to personal choice, how does that change how you think? How does it shift your perspective on your own health, the health issues around you, and maybe the balance between what we do individually versus what we need to tackle collectively?